we face while we manage the abortions in our day-to-day practice. So without wasting time, I would like to go straight away to the session, and I would like to discuss it as case scenarios with question and answers following. So with the permission of the faculty, I'm starting the session. The first case is a 17-year-old POXO victim, 7 weeks gestation, brought for MTP with request for sample collection of the abortus for DNA profiling. She was brought by the police. All these are real case scenarios. And first I would like to ask Nozer sir, sir, can you please enumerate the legal formalities, including the consent forms regarding the sample collection and all?
So as far as the POXO Act is concerned, your responsibility is to inform the police. You don't have any other response. Yeah, that's for Dipti. Plato said good people do not need laws to tell them to act responsibly. Bad people will find ways around laws. Could I have the next slide, please? So this is the Form E for vulnerable women, which is there in the new MTP amendments. So she's a young girl. She is allowed termination up to 24 weeks. That's the latitude the law has now given her. Next slide, please. The POXO Act only tells you that you have to report this to the police. It does not tell you how you have to manage that woman. It does not put the burden of collecting evidence on the doctor. I don't know, there's this misconception that you have to keep it and you have to store it in a refrigerator. Whatever understanding I have of legal proceedings, keeping something in your refrigerator in your hospital is not storing evidence, because a defense lawyer can always challenge that and say that it was accessible to everyone. In this particular case, the police, it's the job of the police to collect evidence. So if they come with the girl and they come and they take the evidence, then that's their responsibility, not yours. Under the MTP Act, you have a responsibility to do that MTP. The form to be filled is as per the MTP Act, where Form C is the consent, and for this minor, the consent has to be done by a guardian. And the last time we amended the law, we took away the Guardian and Wards Act and simplified that as well. So you do the termination of pregnancy, you inform them, they document it, and then they take it forward from there. Interestingly, and if you could just give me the next slide, in the MTP amendments, we brought in confidentiality for the first time into the MTP Act. We've done that. Next slide, please. And now, there was a very interesting Supreme Court judgment. The bench was headed by our Chief Justice of India, who's an absolute champion of reproductive health and rights. And they said that in this exceptional situation, if the minor and her guardian request you, you will report to the police without identifying the minor. There is a Supreme Court judgment as of last September which stands. Just as she's anonymous in an MTP register, she will also be anonymous in the police complaint.
So we need not file a police case for that. That's what.
No, you have to inform the police, but you don't inform the police the girl's name. I know it's a little contradictory because the Act says that an authority can be informed in spite of the secrecy. But the justice said that these girls are going to quacks. They are not going to doctors, and to protect them, if she does not want to be named, she should not be named.
Yes, exactly, sir. Because due to those privacy issues, some parents are a little bit hesitant to report the case. So next question to Lakshmi, madam. Madam, can you just elaborate on the prerequisite, that is including the investigations before proceeding for termination in such case?
She is 7 weeks pregnant. You will have to confirm pregnancy, of course. By a urine pregnancy test is sufficient. An ultrasound scan is not mandatory. If you feel that the uterine size corresponds to about 6 to 7 weeks, it is fine. If you have any doubt or you want to confirm, you can go ahead, but the law does not require you to do an ultrasonography. You will have to do an examination, most importantly. You will have to do a general examination, abdominal, pelvic examination, etc. And just basic investigations like a hemoglobin, blood group and type and urinalysis is sufficient at 7 weeks. The most important thing here is talking to the patient and the relatives since she is a minor, and counseling, explaining to them the procedure that you're going to undertake. If it's going to be medical, explain to her what it involves, how many visits, and what to expect, etc. And if you're planning on a surgical evacuation, again explain to her all the details. You certainly have to fill up the Form C and the Form E, as Nozer explained. Yes, these I would think are the formalities.
So what's your comment on ultrasound? Is it mandatory?
No, it's not mandatory. It's absolutely not mandatory. And this is for us to understand when someone challenges you in future. Because the government, we came up with the comprehensive abortion care guidelines of the government of India, which were updated in 2017. Ultrasound may be considered something you want to do, and many of us do it.
Yes.
We're not asking you not to do it, but if you don't do it, you cannot be pulled up for it.
So it can't be we can't be challenged if we
You
didn't do
cannot,
it.
if the government says in its ministry guidelines, nobody can challenge you in a court of law.
And it's again emphasized there that an ultrasound is not
Okay, madam.
mandatory.
Okay, madam. Thank you.
Yes.
And madam, which method will you prefer for her, medical or a surgical procedure?
I would certainly prefer a medical, but if she wants the sample collection for DNA profiling, and considering she is very young and she may not want to go through the process of, 2 days of mifepristone followed by misoprostol, the uncertainty of it, etc. I mean, how long to wait, etc. It'll be all right to do an use an MVA and do an evacuation, collect the sample, and send it for whatever she wants. But otherwise, I would prefer a medical termination.
Yes, sir.
Medical has its problems.
Yeah.
I agree. In a girl who's only 17, and therefore you wouldn't be wrong if you say you will do a manual vacuum
but-
aspiration and send her home.
Yeah, I would definitely take her. She's 17. She's perfectly actually capable of making decisions. In fact, in a lot of countries, a 17-year-old is allowed to decide. You do not do a surgical procedure just because the police wants a sample. It's for her to decide what she wants. And the advantage of medical for her is no coming to a hospital, no being seen in a hospital, no getting to go into an OR. She can do this in the privacy of her home. And the amazing thing about medication abortion is, while we know there is more pain and we know there is more bleeding, they've shown satisfaction levels of medical abortion as high as 90 and 95%, which means if women want something, they will do whatever it is to get it. So let her decide. There are women who will say, I want no pain, definitely go MVA. There are women who say, I'll do anything to avoid going to a hospital, go medical. A majority of cases, I think we would do a medical.
How to
And if the
collect the
sample can't be collected, that's not your problem, that's not her problem, that's the police's problem.
So the police is always insisting that they just want the sample. They are not at all bothered about what's happening with
What
the
value does a sample have that is collected in a diaper? What value does a sample have that they tell you to store in your refrigerator and they don't even come for 2 weeks or 1 month to collect it? I mean, a defense lawyer would only ask how many people opened that refrigerator? How many people had access to that sample? The moment you have that, that sample will not stand in a court of law.
But if they insist and there's somebody to pick
if
it
they're
up
there
there,
and they come
yeah,
and pick
if
it
there
up.
is somebody to pick it up at the time that you are collecting it, then I think a manual vacuum aspiration all right. But I agree with Nozer. Most of these women, girls and the parents just want to come, get this opinion, take the medication and go. And medical methods are fairly safe. So I think it really depends. If she didn't have this whatever requirement for the DNA profiling, I would have also, my first choice would certainly be medical.
Majority will opt for medical only, madam. And in our setup, what we do is we make her wear an adult diaper after we
Yes,
give
can be done, I
misoprostol.
guess. Like,
And madam, what about the post-abortion follow-up in this case?
the post-abortion, I mean, when you give her the medication, you will have to tell her that this is mifepristone 1 dose. You have to wait for 48 hours for the misoprostol. Again, that's going to, we're going to give it oral. If it is vaginal, she might have to come back. That's your choice. I would prefer an oral misoprostol. And subsequently, I will tell her at the time in the initial visit that if she doesn't bleed at all or if she has an excessive bleed or any problem, she need to contact. If not, she can come, if she's expelled the products, she can come even 2 weeks later. And at that time, you can decide whether you, just do a clinical examination, history and clinical examination is required, but otherwise, you can do an ultrasound scan only if you think that the products may be retained or she's continuing to bleed or continuing to have spotting or whatever issue. A scan again is not mandatory to confirm the completion of abortion. Do I take that, Nozer? Yeah.
No, sir. If I may just ask you, the problem in our country I see is the onus of procuring the specimen and handing it over is now supposed to be with the doctor. The police harass the doctors. That is our problem now.
So Dr. Paili, I think this is where the Federation needs to take a stand on and take a very, very clear legal stand, a legally tenable stand. The chain of evidence, that's the first thing that will be questioned if you're telling a doctor to keep something with themselves. You want a sample, you have to be present, they have to collect it and they have to go. And to make a woman do something because you want to collect a sample is completely against that woman's rights. So I think if you have a statement going from the Federation to your members, they will be able to stand up to the police and talk about confidentiality, talk about the Supreme Court judgment, talk about the fact that the MTP, that it should not come in the way of their MTP. And in fact, the authorities, if this case goes to them, are bound to get this procedure done in the shortest of time and not sit on the, and you definitely do not need permission before doing an MTP. Your job is to report that you knew that there was an instance where this young person has had sex. The consequence of the sex are not, you don't hold treatment until they give you permission to do so. That's not what the POCSO Act tells you.
Okay, sir. So finally, if the patient comes with an ultrasound report showing about retained products of 16 millimeter, how to proceed?
So thanks to modern ultrasound, we sometimes tend to overdiagnose things. And I can just tell you that from my practice, since we've been doing medication abortion for a long time, we analyzed our last 120 patients. And if you did a scan within less than 3 weeks, say 2 weeks, almost 56% had reports of RPOCs. Now, many of these patients might have gone for a procedure, but if you held yourself back and were patient and did nothing and waited for 1 or 2 menstruations, there's a study which says that there is no advantage of giving repeat misoprostol. You just wait. And after the next menses, that incidence just dropped down to 9% and then it dropped down to 7.5%. There is an interesting condition that we are seeing now with medication abortion. After all, medication abortion is a spontaneous abortion started medically. So don't be afraid of medication abortions. We've dealt with spontaneous abortions in all eternity. You might see a lot of vascularity, and that sometimes really causes people to panic. And here a hysteroscopy definitely has a role to play when you're doing that evacuation, because you might have to cauterize those bleeding vessels.
Okay, fine, sir.
I think just having a 1 centimeter, 1.5 centimeter bits of tissue doesn't really, warrant the use of misoprostol just because it's available.
Okay,
I think
yes,
wait and watch and follow up after a week.
Sure, madam. Sure,
and
madam.
if it is still there or becomes symptomatic, you can always use misoprostol. It's available.
Okay, madam. Thank you, madam. Thus, as sir pointed out, this vascularity, mentioning the vascularity is the biggest confusion for the obstetrician, whether to intervene or not. So going to the second case, she's a 20-year-old second gravida with previous LSCS 9 months back, now 9 weeks pregnant, was refused MTP services from 3 hospitals. She took abortion pills, which she got from her pharmacist friend. She presented with fever and irregular bleeding. On admission, she had temperature of 102 with pulse rate of 120 and BP of 80/50. And on examination, there was foul-smelling blood clots. Lakshmi, madam, can you just say what's your diagnosis and how to approach this case, including the investigations and how to monitor the patient?
Well, this lady has an abortion with sepsis, obviously. It's a septic abortion, if you want to call it that way. And the focus of sepsis is the products of conception. Now, she has fever, tachycardia, and a hypotension. She is in sepsis. And therefore, you need to look at her cues. Yesterday, I think people discussed
about that, madam.
How to score it with the Q sofa. You need to admit her, bring the blood pressure up. You need to send a blood culture because she already has fever and hypotension. Start her on intravenous fluids. You need to do the 1 hour bundle. You need to use that and start her on a broad spectrum antibiotic. Even a piptaz flagyl is all right in this kind of piperazine tazobactam flagyl because if she's already gone into gross sepsis. So you don't start with the first line antibiotics here. Do all the investigations, including lactate.
Madam, which antibiotic you will prefer?
I would, in this situation, I would go in for a piperazine tazobactam. You could do augmentin. You could use a third generation cephalosporin along with metronidazole. I'm sure the choice of antibiotics will vary depending on where you are and what your organisms are.
Okay.
But I would definitely go for a higher level of antibiotics, yes. And once you stabilize her, by way of IV fluids, antibiotics, in about 24 to 48 hours after the antibiotic is in, that the products have to come out because that's a focus of infection. And before you proceed with anything, you need to certainly do an ultrasound scan considering the history of a previous cesarean section, or even otherwise in this situation you need an ultrasound scan. I'm not going into the details of how we are going to manage the sepsis, which was discussed yesterday.
Okay.
So we will go in for following the ultrasound scan. If she is stable, blood pressure is up, even if she's still febrile, you have to evacuate. That's
So you should wait till 24 hours for evacuation.
yes.
24 hours. Okay. Nozer, sir, do we have to give a police intimation for self-administration of abortion pills?
So there's nothing in the law which makes you liable to tell the police that this patient came in. She's just given you a history. She may not have given you a history. Technically, it's hearsay. So no, you do not have to.
No,
Please understand that that would only put the woman in further distress besides a medical condition. Okay. As far as this situation is concerned, it brings to mind that if you don't give a woman an abortion with dignity, she will have that abortion anyway. In fact, if there's someone to be investigated, it's probably those 3 hospitals and not the woman. They are responsible for the septic abortion. Because when you try and deny abortion, you only deny safe abortion, you never deny unsafe abortions.
So your comments about safe abortion practices in India?
I just want to share this with you because this is something that I think we need to keep uppermost in our mind. 27 million births in India, the latest estimate is 17 million abortions. It's the second most common thing in a woman's life. And she still has to struggle to get it in a state like Kerala where 3 hospitals refuse her. If you go back to the previous slide, this was a study done by the Guttmacher Institute in India with IIPS and with the Population Council. And they showed that half of our pregnancies, 48 million estimated pregnancies, are unintended. I mean, let's take this as a wake-up call. And 17 million abortions, and we've got just about 8 lakh MBBS doctors, including every specialty. Could I go to the next slide, please? And what we found in the study was that today abortion in India is primarily medication abortion. Abortion in India has moved out of health facilities. Abortion in India is almost 13 million medical abortions to a handful of surgical abortions. And unfortunately, many of these are self-managed abortions like this one. Why are they self-managed? Because they are being turned away, because it's too expensive, because of confidentiality issues. And could I have that last one slide, please? And this is the reality worldwide today. I would say more than 50% of abortions are self-managed. Not the best way of doing things, but until you give women the option of places to go to and have it safely, this is what women are going to do. Welcome them, don't condemn them, do not turn them away. This is their contact with the system. Send them back safer and better. When they do self-managed abortions, my only problem is it's better than going to a quack and getting something dangerous done, but there are 2 problems. There is no counseling as to how to go about it, and there's no post-abortion contraception. And that is what women are entitled to.
Sir, your comments, so one more question I would like to ask. In which all grounds abortion services can be denied to a lady?
See, medically speaking, in India, abortion is not something you get on demand, which is sad. We tried to get first trimester abortions on demand. Abortions, but the Indian gynecologist has been pretty good. He's done or she's done the abortion very, very liberally for women. When we did a survey in Foxy, we were very, very impressed to find that in India, almost all obstetricians, this was 440 random obstetricians, almost 90 to 95% perform abortions in their practice. So conscientious objection, as the country is concerned, is 5%. In some states, it is more. You cannot force a doctor to do something they want to do. I respect that. Doctors have the right to choice as the woman has, but you can't put that woman's right at risk. The South African law says that if you don't want to do it, that's fine. You are legally bound to refer it to someone who will. And I think it's time we started doing things like that. That woman should have gone to a place after the first hospital, not been turned away by two more, she would not have landed up in this situation.
So that's what, because in the government sector, what we are facing is that some doctors won't like to do because of their some personal consciousness, that is religious beliefs and all. That time the patients and bystanders will argue that you are bound to give us the service. That's
Reference is a service. Referral to another center is a service. There are things that you may not do in your practice, but when you can't take care of it, you send a baby to an NICU. So you can say, I do not do it for my own moral reasons, but go to I get colleagues who don't do abortions, who refer their abortions to me. The patient gets her care.
Absolutely. I worked in an institution where majority of my colleagues didn't believe in doing a medical termination, and therefore I did have to refer. But I would take it on, or will certainly send her to one of the other colleagues who would do it. You can't send her away. Yeah.
So since the time is up, I think I will wind up the session. I'm extremely thankful to my faculty for throwing a light on some gray areas. And I hope this session was useful for all the practitioners who are assembled here regarding the queries you face in day-to-day practice while managing an abortion case. Thank you.
Yes, of
Thank
course.
you, Nozer sir.
Thank you,
Lakshmi
Parvathy, for
ma'am.
that very interesting questions, and our Nozer sir and Lakshmi madam for that very, very useful answers. Thank you, team.